Hi, everyone. Today, I'm really pleased to welcome Professor Paul Estabrooks to IS-PEC Talks. Paul is Associate Dean of Community Engagement in the College of Health at the University of Utah, Professor in Health and Kinesiology, and Director of the Mountain West Prevention Research Center. Over the past 2 decades, he's been a leading voice in applying behavioral science and dissemination and implementation science to increase access to health promotion and lifestyle interventions in both clinical and community settings. Many of you will know Paul as one of the founding collaborators of the National Re-AIM Workgroup, which has shaped how we think about reach, effectiveness, adoption, implementation, and maintenance in real-world systems. His work spans rural health, digital interventions, diabetes prevention, obesity treatment, and building community capacity to support sustainable change. What I especially appreciate about your work, Paul, is the consistent focus on moving beyond efficacy, asking not only does this work, but well, who does it reach and who adopts it? And how do we sustain it in real systems with real people? So thank you for all the work that you do. We're so glad that you're here. So let's jump right in. You were part of the development of Re-AIM more than 2 decades ago. For listeners who may be newer to the field, can you briefly explain what Re-AIM was designed to address and why it was needed at the time?
Sure. So that was when I first started collaborating with Russ Glasgow in 1999 was the year that he had published with a couple of other colleagues the initial Re-AIM paper. And I came to it from a little different perspective where I just finished my doctoral work in physical activity promotion using group dynamics for older adults. And like every good graduate student, I really wanted to do something important, but I had no money or real resources to do anything important. But I wanted to do some intervention work, and so my mentor at the time, Dr. Burt Karen, arranged a meeting for me with the Victorian Order of Nurses, who hosted older adult programming just outside of London, Ontario, where I was, and were interested in maybe doing a physical activity program. And so I worked with those folks. We created a physical activity program that fit the resources they had and the needs they had in their community. And we tested it out, and it worked really well to improve adherence and return rate to the program and all that stuff. And and so I was super happy because I was focused at that point on the idea of effectiveness. I just wanted to know, does this thing work to promote physical activity? And what I realized shortly after I finished my PhD and started working a little bit more with Russ was that I'd kind of stumbled into what was going to be the career trajectory for how things have moved forward for me. But it was really understanding that what I developed together with the Victorian Order of Nurses, and we definitely developed it together, ended up being sustained for many, many years after my doctoral program because it fit well within that system. And so then we started thinking a little bit about, well, why did that happen? And this is where I'm going to get to answer your question. It happened because we started thinking beyond the idea of just effectiveness. And I think the reason that Re-AIM came about when it did was almost in parallel with the evidence-based medicine approach, which was starting to look at things like participant, intervention, comparison, and outcome, and really wanting to define clinical questions very well, which is good because then you know what something is that you're testing, and it's good for specification to come to an outcome. But within those models, a lot of times what they were doing was kind of eliminating any kind of variability in the context or the participants or the way that the intervention was developed. And
Or
so
the
you
real
ended up
world?
with
They were just
not the
eliminating the
real
real
world stuff.
world.
Yeah. So you ended up with things that were just worked really well under tightly controlled conditions. And so really Re-AIM came about to say, well, that's an important thing, but if we want to scale things up, we kind of need to know, how would this be adopted in other settings? Could it be implemented with the resources that are available there? Can it be sustained beyond the research funding that's getting it started up in these situations? And then most importantly, I still think is, who does it reach and who does it benefit? And is there potential that you might be leaving out those that could benefit most because they're not often the populations that engage in our research studies? So that'd be kind of the high level, probably a little more than you and you're
Right.
bargaining for with that question.
No, no, but that's great. So Re-aim addressed that, but it has evolved over time. So can you talk a bit about how, because what you're describing sounds, well, that's perfect. That's exactly what we need. And that was how Re-aim had started. So can you explain a bit about the evolution and the iterations of Re-aim?
Absolutely. I think that when it started, kind of from that 1999, maybe to about maybe for 10 years, really what it was a lot of times was descriptive. So we would describe how we recruited folks, and we would describe the folks that engaged in the studies and their representation of different groups across the population, and in particular those that typically don't get to benefit from these types of interventions. And so we would really be reporting out on these contextual factors from a descriptive standpoint. And then it kind of transitioned from there. And I think during that 10 years too, people were starting to use it as a way to design interventions. So right from the start, thinking about, well, how's it going to reach the folks that could most benefit? Who are the systems that work with those folks? And so if those are the systems that work with those folks, would they prioritize this? Would they have the resources to deliver it? And then what would that implementation look like? What would the workflow be? How well could folks be able to keep up with the intervention fidelity as we think about it? And then how might it be sustained once we're gone? And so at that point, things really did start to move from we're designing interventions for dissemination from the perspective of reach, adoption, implementation, and maintenance. And then I would say that probably, you know, Russ also published the work on the PRISM, the practical, robust implementation and sustainability model, which was intended to build out context around re-aim outcomes. And I would say that's pretty much where we have evolved to now from the standpoint of being able to not just design a strategy to increase reach, but design a strategy to increase reach in a particular population based on specific mechanisms related to how well does it align with preferences of that particular population? How well does it align with their priorities and their resources? And so we start to think about strategies that can affect those mechanisms to increase the specific re-aim outcomes. So it's really started to move a little bit more into causal science, like how do we actually do this, and then what are the reasons that underlie why change happened?
So can you give me you spoke about your doctoral work through when VON and increasing activity among older adults. Can you give me a recent example and how, the maybe PRISM or the newer version of REAIM, how that came into play?
Yeah, I think one that is a really kind of a different area. Is we're doing a project right now on how best to operationalize rapid whole of genome sequencing in the NICU. Very different content area. But at the end of the day, one of the things that we wanted to investigate was how do we make sure that every kiddo in the NICU is able to benefit from this advancement, regardless of where they're from, all that, all of the things that could be around that child. And one of the things that we wanted to do was build a toolkit for health systems to make sure that you take rapid whole genome sequencing, maximize its reach, improve its adoptability through specification on what the system needs might be in terms of electronic health record changes, communication and workflow, and then how it might be implemented in a way that works within the crazy schedule of the NICU, where you have full shifts and rotations of people on a biannual or biweekly basis, where a whole new team will come in that's never interacted with a family that oftentimes is in kind of a crisis type of situation. And so that communication component to it, and then how do we generate this all so that it can be integrated and institutionalized? And so within that, one of the very simple things that we've done is we've created, and again, based on PRISM, which has this multi-level conceptualization of characteristics of populations as well as preferences and perspectives. And so we started with what we call our collaborative group meetings. And we have a collaborative group meeting that is just with parents of kiddos who have been in that situation and experienced it. And then we have another one of providers, which is everything from physicians to genetic counselors to whoever might be in the NICU workflow. And then the last group we think about are administrators and the technical folks that would make decisions about how changes can be made. And so through our process, and we're only through our first two collaborative meetings, which with each at each of those levels, and we have a third one that will end up helping us to be able to produce the toolkit that would be most beneficial to maximize re-aim outcomes. With that, we were able to get at perspectives that, a really one that always jumps out at me is listening through parents talk about just the just the challenge of getting sometimes devastating news in a public, it's not public, but in a venue where there's others, or even if grandma is there and maybe dad don't want grandma to hear this way. Maybe they want, so just this idea of communication. And so, based on that, need for, kind of just more attenuation to the privacy of the conversation. When we get into the providers, they also identified having gaps and a lack of surety how to communicate information, especially when it's hard information, because sometimes rapid whole of genome sequencing will show something that we know what it is, but there is just nothing really that can be done about it. And so how does that happen? And then when we get to the administrative side, a lot of things in the technical side of things are around in the electronic health record. How can we make sure these communication pathways are smooth? And so within the toolkit, we'll have a number of different things that are focused on each of those groups in the efforts to improve the reach, adoption, implementation, and maintenance of that particular innovation.
So, I mean, it sounds like you map out the different groups and then you speak to them as many times as necessary. Are there, I'm trying to think of how to verbalize this. You've held a lot of leadership positions, right? And you talk a lot about community engagement. But what would be the most common mistakes or pitfalls that researchers should avoid? Because what you've described now seems to work. So what has not worked? Or can you tell me a bit about, oh, I shouldn't have done that in that project and I did something along those lines?
Oh, yeah. Well, this is a common pitfall, and we have had this issue too, even with our Prevention Research Center right now. Like, it's one of those things as scientists that on occasion we will see a call for proposals and we're like, oh my gosh, that's perfect. It's right in line with scientifically the things that we do. We have partners that we think would be able to benefit from this and would prioritize this. So we're going to go for it and write it up. And as we did that, we realized the window was a little too tight for us to get really good buy-in from our community partners, in particular, community health centers in rural areas. And so we kind of wrote a letter of support that was signed by our folks that interfaced with those centers and some center representatives, but we couldn't really do the strong letters that we usually have where, yes, we're going to do this when it happens. And of course, we were successful in getting the funding, which we're very happy about. But what we found is that rather than us, as we would have preferred to be hitting the ground running and doing the project within the first 12 months, getting it up and going, we're realizing that it's taken, and we're very close now to getting things up and running, but it's taken closer to 18 months to 2 years to be able to get things in place where we really are able to still meet the needs and the priorities of our partners. And so I think the big mistake is getting in too late. That's always like thinking about it too late. I'm going to write this grant and then I'm going to talk to people because they'll want to do this because it's such a good idea. So that I would say is probably the biggest thing. And then I think another thing is like sometimes we write about engagement almost like it's a product rather than a process, right? And so, really, I think another mistake is not thinking of partnership as a shared governance to what you're doing. And sometimes that can just lead to misunderstandings. And, ultimately, from a scientific perspective, what it will lead to is that something won't be adopted, implemented, or maintained because you just haven't developed the partnerships or you haven't designed something that aligns well with partnership priorities and resources. Um, let's see. And then this is one that is not just to us and Reaim, but everybody talks about the helicopter researcher, right? Like make sure that your work's not just extractive. I just jump in and extract the information and go away, and the community never hears from me again. So I think that's a mistake of just not planning in communication. And then I think the last thing I would say is one of the challenges is being overly positive about what you might achieve together. And that doesn't mean like I always say you can't get to Paul without having Pollyanna, but I'm always very optimistic about things, but sometimes the best laid plans, things just don't work. Maybe they don't reach the folks that it wasn't attractive to the intended audience. And so, you have to be ready that if something doesn't work, we're going to be able to have some plans on how we regroup and think through. And sometimes if you start with the bar really high, that can actually lead to mistrust later in the relationship.
But I always tell my students, meaning positive findings, neutral or negative findings are also very, very, very important. You don't always, you need to know when things aren't going to work. You need to know that not to invest millions in expanding this process or this intervention. You need to know that this doesn't work. And that's a good finding.
Yeah.
It's any finding is a good finding. It doesn't have to be positive. Okay, yes, the journals may not publish it, unfortunately, but it's an important finding.
Yeah, and I think Mariah, the big difference there for me is that for us as scientists, that is absolutely true. For community partners, that is not always true,
Okay.
right? Like for them, a lack of a finding scientifically, it is important. It's important for the community, the distribution of resources, being good stewards of what resources you have. It's good to know if something doesn't work, but sometimes, you've spent 2.5 years designing, testing, and then it comes out and there's just a deflation. And so
Right.
you're exactly right. And I think that even your framing up on the front end with that kind of shared community and scientific governance of the work that you do is the ideal thing to do. We know that anything we find is advancement. And even if we don't find what we're hypothesizing, we'll find that's okay too. But we just have to have plans for
Right.
what's the pivot.
Right. Okay, so let's end with one bit of advice. We usually like to end with some advice for our students, but you could also reflect back to when you did your PhD. What would your younger self, what advice would you have given to yourself, where you wanted to really influence real systems and not just publish in journals? We need to balance rigor, we need to balance impact, we need to balance relevance, but in the end of the day, we want to have an impact. So, what type of advice would you give the younger Paul?
I feel like, as I'd said earlier, I feel like I kind of stumbled into some things just because of the contextual factors and the good mentorship around me. And so maybe that's one thing I would talk about is, find a good mentor. And especially if you're going to do community engaged stuff, find somebody that aligns with your passion for the work that you do, with your content area. And it doesn't have to be the exact content area, but you definitely have to have that alignment and has established relationships with community partners. I think that really can speed things along for new folks. And then within that context, understanding that there's always going to be the push and pull between promotion and tenure that says you need to be an independent scientist and real world impact, which means you should be okay with not taking credit for stuff. And even if you were kind of deeply involved in that in the community, it's okay to let go of the credit. And so kind of being aware that that push and pull is happening and trying to, as you go through the work to advance whatever scientific advancement and community impact that you have, I would say also write that stuff up as you go. Process papers are outstanding. Any type of learning, lessons learned types of papers, and then I think you can balance those two kind of critical tensions that you have as an early career academic.
Amazing. Thank you, Paul, for your time. I really appreciate it.
No problem. Thank you.